You started by indicating 5% of the population is responsible for a significant portion of health spending. I'm curious if the population shows particular qualities that we might recognize when we review cases other than being costly cases. Do they follow populations, certain diseases, certain tests, etc.? This is Dr. Wood or Dr. Grundy.
Multimorbidity. So the high-cost cases are those people who have multiple conditions, often with one behavioral health condition.
Thank you. Dr. Grundy, I was intrigued by your comments regarding the science around awards. How does this affect physician performance? E.g., is there a tendency to concentrate on easily measurable outcomes to the detriment of even more important aspects of care that can't be quantified with numbers? Also, does this type of financial motivation detract from a doctor or PT relationship based on altruistic motives, such as providing the best care possible to one's patients regardless of payment for specific components?
Well, frankly speaking, I mean, you are working against rewards now. They're just inappropriate and misaligned rewards. And if you begin to align the rewards more appropriately, I think that you will be better served. The fact of the matter is, where this works the best, it's where you, the providers, say, these are the 3 things that we're going to start to do to hold ourselves accountable to. That's how Blue Cross Blue Shield of Michigan did it. That's how we got the changes in Grand Junction, Colorado, right? Rather than boiling the ocean, you know, what are the 3 things that you want to hold yourselves accountable to, responsible to, and how can we reinforce that by how we pay you for keeping and holding yourselves accountable to that? I mean, I just don't know of any other way of doing it than beginning to try to at least align payment in a bit more effective way than, you know, simply saying to you, if you see the whites of the eyes and you do something on somebody, we're going to pay you. I mean, there just needs to be more reward systems put in place. I think those reward systems are best designed when they're designed with the physician saying to us, this is my practice, this is what I'm going to hold myself accountable to, and this is what I want to do, right?
Assuming A, shortage of primary care physicians, B, high cost of physician services, C, the need most patients, including each of us, to have more time for bidirectional communication related to each of our health, to have support guidance over time to change, maintain healthy behaviors. How do you see healthcare manpower, woman power, evolve and change?
So there's a recommendation in the roadmap that the doctor would reference around precisely that question. How do we meet the demographic needs, the likely expansion of access to primary care via the ACA, the diverse populations we have? It contains a multitude of recommendations related to, for lack of a better word, workforce development around primary care. And it includes a number of different strategies around sort of enhanced loan repayment, around connectivity with our higher education system, around identifying, for you guys, I don't know how you like this, it also involves alternative delivery structures for primary care from other professions. And it talks about sort of multiple strategies by which we meet that gap between folks that are in need care and the folks being there to provide that care. Now, some of the sort of interesting synergy that could occur would be if you do things like payment reform and if you do things like coordination of care, does a individual practitioner, if they don't have to spend as much time on less value-added services like, you know, filling out forms or being sure that they bill for a certain amount of services, do they become inherently more productive and therefore get to see more patients? I don't know. That's an interesting dynamic that I haven't thought about, But that might be another strategy by which I think it's a fairly shared observation. The gap between supply of providers and the need could be met.
Yeah, there's a related question about physician manpower imbalance, primary versus specialty, number of physicians and income. How well should this evolve, rebalance? And
I would just add one thing about single payer and the primary care shortage. I mean, it's going to exist whether we do a single payer or multi-payer system, but one thing to be gained in single payer, like I mentioned, is a significant number of hours in our week that are currently spent dealing with the problems that arise because our patients all have different payers. So filling out all those prior authorizations that are different depending on who the payer is for your patient, there's a lot of time to be gained there, which again can translate into more patients seen. So one of the ways to address the shortage is that it's not going to be sufficient, but it's an addition.
thank you. Minnesota has shown how not to establish healthcare homes. High burden to be certified, health plans who make payment as complicated as possible. Total cost of care programs prevent small community-based entities from sitting at the payment table with health plans. Tell me why, as a family physician working at a critical access hospital in rural Minnesota, why I should believe reform in Minnesota will actually value the family physician and will hold prayers accountable to reward me for transforming my practice and getting to cost containment.
So, a couple of things. One, when we think about the problem of payment for coordination of care in medical home, as we were going through the work of the Governor's Task Force, we heard consistently testimony that the payers were not, especially the private payers, were not consistently paying for those services. So the Department of Health actually knows that and is actually working to try to improve that circumstance. I was encouraged in talking to Paul before the meeting that in the discussion that you and Paul and others had with Blue Cross Blue Shield this morning, they've decided they're now all in. So I think we're beginning to see the tide turn. From the perspective of working in a small practice and total cost of care, the task force and the work group that I led recognize that total cost of care will not be the payment mechanism that will take care of all care in the state of Minnesota. Accountable care will be important, but it may not be that every circumstance is done with a total cost of care contract. So there are several ways then we have to think about how we will then pay for those services. Now I would also say that if you come back to the issue of a critical access hospital, this is one of the problems we have with how we have driven payment in the country. So in Medicare in particular, we drive payment according to the silo of where care is delivered. So we'll pay a critical access hospital on a cost-based method, and then we'll pay the physician separately for physician services. If we actually looked at the total amount of money we spent in that community, we would be smarter to say, I'm going to pay the hospital less and pay the physicians more for taking care of chronic care. Now, in my previous career as working in some of those communities, today I would actually look at the prospect of closing a hospital in a small community and changing my focus to care of the total population and tell Medicare, just give me the $3 million you gave the hospital and the clinic last year. I'll take the whole $3 million and I'll do better than what you're getting by paying the hospital and the clinic separately.
Thank you. Our final question, and we touched a little bit on this, but this is a little bit different. How can we engage communities from a business model if the businesses that are able to generate at economies of scale after often produce products that contribute to disease is focusing just on the health sector is a Band-Aid?
Wow. So let's talk about tobacco as a fairly obvious example of a. I was recently in a meeting where they talked about public attitudes about what do you do with tobacco. I think the most encouraging thing I took away from that is that no matter, and by the way, this is remarkably even, no matter what your partisan orientation, there was there was majority support for increasing the tobacco tax for the purposes of reducing tobacco consumption. Because I think we've gotten to the point in our society where people accept that that is, you know, a product that generates cost to the system. And the best way or a way to address those costs of the system is to raise the cost of the consumption of that product. Not surprisingly, the minority that opposed that was strongly centered by folks who smoke today. So, so I would say that there are a number of public policy stratagems by which you deal with products that cause harm disproportionate to the benefit they theoretically provide to society. I think the challenge in any of those stratagems is that there is other than tobacco, there is a disagreement about whether or not that's government's role to externalize those costs. And I would say that the upcoming debate on the president's gun control measures is a perfect illustration of the disjunction between the recognition of costs and the willingness to say government has a role in externalizing those costs.
Thank you. You've had the last word, right, Manny?
One of the questions that kind of got passed on a minute ago was the breakdown in distribution of specialty versus primary care. When you look at systems that work, that really work, right? When I have employees that I see that are managed and have 1/3 less need to have heart surgery because there's robust primary care, those systems spend about 20 to 25% of total spend on primary care. You know, there are systems in the United States that do that, and in fact, the insurance commissioner in Rhode Island looked across where delivery systems of value occurred and basically mandated by law that percent was spent by the plans in Rhode Island, and we've made a huge change there because of that. For the average buyer of care like IBM and other large companies, the spend now that we have for primary care is 5%. It's literally upside down pyramid, right? We spend all of our money on high-end procedures, oftentimes on people who are going to die 2 weeks later, and we spend very little on preventing that from occurring. So, I mean, that whole pyramid is beginning to be flipped upside down. And I think here in Minnesota, your spend is about 6 or 7% on primary care. And I mean, it really needs to go up into that sort of 20 to 25% range if we're going to have a system that balances. Most civilized nations also do about 90 to 95% of total care in primary care. I mean, that's what primary care does. And, you know, it's kind of like the adage of, eat, not too much, mostly vegetables, yeah. Health care, not too much, mostly primary care.
Well,
broccoli's good for you.
yes.